and Bill Heald, all kind of sitting together there at the Royal College of Surgeons. No one seemed to be interested, but it's really grown. I think we'll probably have about 700 people in Berlin, and that's a big difference from 20 years ago. Okay, do we have general surgeons in the room? I recognize. So there's just a couple of general surgeons. Well, what is cancer surgery? And what is optimal cancer surgery? Well, we've got to clear the malignancy, right? Got to remove it. It's not the only thing the surgeon must do. He must contain it. It's not good to squish it as you remove it. That's you know, that's death knell. Those cancer cells, one or two of them free in the peritoneal cavity, are going to bring the patient's death within a year or two. But I think that now, for me, a third essential component of the knowledgeable management of gastrointestinal cancer is this use of cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. Now, again, cancers are really devilish. It's a devilish disease, and it doesn't just, you know, grow within the colon or grow within the appendix. It's going all over the place, and we have some pretty good strategies for liver metastases. We've come a long way. And I don't know whether I'll get to the slide, but for me it's a little bit deja vu. I mean, 25 years ago we were arguing with the medical oncologists, is it reasonable to resect liver metastases? And of course it's now standard of practice. And of course we always remove lymph node metastases. Why don't we go at this peritoneal surface component? Why is it that we don't have a plan of attack on the peritoneal surface component of gastrointestinal malignancy? I'm going to run over these slides just ever so rapidly, but the first success story, and thanks be to this research foundation because you focused on this success. The one treatment or management plan around the world that is basically now accepted as the standard of care is the treatment of the appendiceal mucinous neoplasm. Now, this is going to change very rapidly, but looking at the research, and if I take my patients, 350 of them, and I match them, and a statistician will say this is, you cannot do this, I have to apologize, this is like, you know, one manuscript matched up with another manuscript matched up with another. But you know, some of the most prestigious institutions, Memorial Sloan Kettering Cancer Institute, have not been successful with pseudomyxoma peritonei. Now they're successful for a short time. Out here to 7 years, their treatment plan is just as good as mine. But in the long run, when you have the 20-year follow-up, they're not successful at all. We could talk about why Memorial Sloan Kettering has not advanced to chemosurgery, and I think there's a number of different reasons, and I think it will change. You know, at ASCO there was, it's kind of funny, there was a debate at this very prestigious American Society of Clinical Oncology, chemosurgery versus no chemosurgery. Do we have evidence for it? And the person arguing against it, very nice, young, very nice medical oncologist, said, oh, well, at our institution we've decided not to do this because we just don't have evidence to do it. And then I think to myself, you know, their surgical oncologist is just talking to me on the phone, and I get an email the next day saying, we now have an established program at the Massachusetts General Hospital, and we're up and running. And I think Laura Lambert actually has a lot to do with that, because she basically challenged the ivory towers there in Boston to say, listen, you know, this works. This really works, and you need to get on with it. So here's the medical oncologist, one hand, saying, there's insufficient evidence for this and then on the other hand, we're getting an email circulated around the country, MGH is open for accrual of patients with carcinomatosis. So anyway, I think that based on historical controls, this concept really does work for pseudomyxoma peritonei, and I think it will work. You know, that we've learned that histology makes a big difference, and I think, Jesus, you're going to present some of this data also on appendiceal. Peritoneal cancer index, the volume of disease, is important. And prior surgical score, not so important. I'm not quite sure why. But you know what? The touchstone, the most important thing about cancer surgery for carcinomatosis is the same as for every other disease that we operate on. You've got to get that R0 resection. Here we call it a CC0, completeness of cytoreduction 0 R1. If you're going to leave anything behind, it has to be just little minute pieces of cancer. And here we have the survival over some 20 years of patients with pseudomyxoma peritonei who had a complete cytoreduction, and that's about 80% of those people who are alive and well at 20 years. And it's people who have an incomplete cytoreduction. Now, a lot of good research could go into, and we've looked at why do we have incomplete cytoreductions, and a lot of it just has to do with the vagaries of this disease. I noticed that it's a rare disease with common symptoms. I mean, the diagnosis of this disease is doesn't hit you in the face by any matter of means. It can be a problem. And even with the PMCAs, PMCA is the mucinous adenocarcinomas. In other words, it's more aggressive appendiceal malignancy. Still, the difference on this blue line here of survival, about 40% of the people alive at 20 years, is so much better than the survival of those patients who have an incomplete surgical event. Lymph node status doesn't seem to make much difference in this appendiceal malignancy. Too fast. Okay, I'm just saying this is the standard of care. Don't let anybody tell the PMP Research Foundation you need to do a randomized controlled study. Does chemosurgery work, or should we go back to surgery only? I wouldn't fund that project if I were you, to tell you the truth. I've taken care, I'm old enough to have taken care of a number of pseudomyxoma peritonei patients who were managed by surgery only. And I realized that we do have a conceptual change in surgery for peritoneal surface malignancy. We now know how to use peritoneectomy. But that's not the only difference. I'm convinced that the difference is the complete resection, which requires peritoneectomy, combined with the chemotherapy washing, which removes and or eradicates in some way the residual tumor. Let me move on. So, one of the things that we are trying to do now, and this comes out of some very nice clinical research work that was done in France, leading the way for us. We're taking on a lot of patients now who have a ruptured appendiceal mucinous neoplasm, and we're actually taking them back to surgery before they develop extensive disease. And we're accumulating these patients rather rapidly because surgeons around the country are aware of the fact now, due to research efforts with pseudomyxoma peritonei. They're knowledgeable that 2 years, 3 years on down the line, this path report that says this is borderline malignancy is going to be a lethal process. All right, I should just say, you know, next weekend is the Mesothelioma Applied Research Foundation meeting. I don't know why they have so much money, but I think it has to do with the litigations and the like that take place in mesothelioma. And if you look at the donors for MARF, Mesothelioma Applied Research Foundation, most of them are, all of them I think, are these are the various legal groups that deal with mesothelioma. But we're doing pretty well using now strategies developed for PMP and applied to peritoneal mesothelioma. And I think your speaker last year was Dr. Alexander. Is that right? And he's got some nice, really nice survival, long-term survival with peritoneal mesothelioma. And if you ask the question, well, what about systemic chemotherapy for mesothelioma? Doesn't it do something? Well, you know, it probably does nothing in terms of survival. You're still 6 to 12 months, even in selected patients. 6 to 12 months with peritoneal mesothelioma treated by systemic chemotherapy. It's just not effective at all. There's never been a trial, systemic chemotherapy versus chemosurgery, and there never will be. I mean, it's very similar to PMP. We have such good results with one treatment, and we have really no results at all with another one. So there's, with the wonderful drugs now, we now use the amitrexid and cisplatin. We use intraperitoneal amitrexid, or Alimta, and systemic cisplatin. And we're very proud of our results that are going to be presented next weekend with phase 2 study of peritoneal mesothelioma, now using bidirectional chemotherapy, using some of the chemotherapy given into the vein and some of the chemotherapy given into the peritoneal cavity. And you know, the pharmacology of this and the doses and schedules and that sort of thing that you can think of are almost, that's mind-boggling, but we've come to some conclusions as to how they should be used, and we're actually very proud of intraperitoneal pemetrexid and systemic cisplatin, and really taking some people who I thought could make it even a few months into long-term survivors. Okay, well, the Mesothelioma Applied Research Foundation is definitely behind us in this. I think in some respects they're a sister group to your efforts. And really great progress has been made. Now, Laura Lambert, I think you talked about someone we talked to prior to this meeting. What about this huge disease, 150,000 new cases per year in the United States, colon cancer? And what about the treatment of peritoneal metastases? Well, there's some beautiful manuscripts, and I focus on this Sanoff paper, where they treated cancer patients who had metastatic disease with systemic chemotherapy, and they had about a 5%, maybe a little less than that, 4% 5-year survival. And there were no long-term survivors, except, if you read Sanoff's paper carefully, except those patients who had additional surgeries. It looks like that 5% were people who had chemo, probably a chemo response, and then more surgery. But in this manuscript, and in all the other manuscripts written on systemic chemotherapy for appendiceal malignancy or for colorectal malignancy, you cannot find how many patients with peritoneal metastases were treated. And actually, it's probably only a few percent, probably less than 5%. And those people are going to do most poorly. In my clinical judgment, those are the people who are going to have the very short survival with systemic chemotherapy. Generously, maybe there's a median survival of 20 months with a 5% 5-year survival. With what is generally being used throughout the United States, and probably Dr. Esquivel will have more to say about this, what is generally used throughout the United States is extremely inadequate. And there is a better alternative. And I'd like to just show you some of the data very quickly that this huge disease process, 10% of the patients are going to die with, at least 10% of the patients are going to die because of their peritoneal surface component of the disease. I think we can have a real impact. The Dutch, Frans Zoltmulder, worked with us, set up this trial. I don't know how he did it, but he completed this phase 3. In other words, half the people got systemic chemotherapy, and half of them got chemosurgery. Very important phase 3 study published back in 2003, Glahan's registry, systematic reviews, many phase 2 studies, now recently the multi-institutional French study, the multi-institutional Dutch study. Okay, we're looking at about a 40% 5-year survival. I think we can do better, actually. I think we can bring that up to 50% with modern chemotherapy, better patient selection, and perhaps some more aggressive use of intraperitoneal chemotherapy. So we're looking at basically no long-term survivors versus 40%. Pretty big difference. This is the Sanoff survival curve. Just remember how everything is basically going down to near zero here at 5 years. And let's just take a look at some of the other data. Okay, well, this is the Dutch trial. Here in blue, Victor Verval's continued efforts. This is the French trial. Now, Dominique Elias makes an important point when he presents this multi-institutional data from the French collaborative efforts. Notice this is now basically every French-speaking group that performs cytoreductive surgery in high-tech. They all put their data together. I have trouble even sending my data to Dr. Esquivel because of institutional problems with patient confidentiality and the like. But Dominique says this is the worst study we will ever report. 28 institutions over about 20 years putting their data together, and with those very early efforts, they still outperform the systemic chemotherapy treatments in a really amazing way. So I'm looking forward to the next French report, and I think that probably it's going to be up here at 50%. We're going to see a 50% long-term survival in patients with peritoneal metastases. The data from Dominique Elias, very nice long-term survival, about 40%. And the peritoneal cancer index does make a difference. And of course, the touchstone is the completeness of cytoreduction for colon cancer now, as well as for mesothelioma, as well as for PMP. Having a surgeon who's been well trained and knows the importance of the peritoneectomy and knows how to perform those visceral resections and put them all together as a cytoreductive surgery is incredibly important. And it's a challenge to the leaders who are here to make sure that the estimate is now there's 120 treatment centers in the United States. Estimate is 120 treatment centers in the United States. that those treatment centers are offering a management plan and a management expertise that is equal to what you, the patient, expect. The survival with systemic chemo, this is the manuscript I was talking about, where you do half as well if you have peritoneal metastases as compared to other types of metastatic disease, such as, for the most part, liver. Okay, so there's no evidence to support the use of systemic chemotherapy, but a lot of evidence, in my humble opinion, to support. Now, you might say, oh, well, and we just went through this in an agonizing way at the American Society of Clinical Oncology, was it 2 weeks ago or last week? I can't remember. And they're just saying, okay, well, you have to have more data. Well, this is a nice paper from Shiga, Japan. And as I said, you know, this thing with peritoneal metastases is kind of deja vu for me, having started doing liver resections back in the late 1970s, and having a lot of resistance from the medical oncologists saying we were crazy, you couldn't possibly have a surgical impact on metastatic disease, we just need drugs and more drugs. Well, Dr. Kaido says that there is no level 1 evidence supporting liver metastases, and yet it's standard of care. You're not going to take that away from us. And the survival in the treatment of liver metastases is virtually identical. And again, I would say this is early efforts with CC0, CC1 cytoreductions for me. But early efforts, we're now doing considerably better on that. But when this slide was made up back in 2003 by Philippe Derch, who runs the carcinomatosis program in Zurich, Switzerland, it was a very, I think, a very meaningful analogy. Now, I'm not looking at Dr. Esquivel right now. I'm looking away. You know, some things just make sense. And this manuscript, published from Oxford, really says that you don't always need more randomized and more randomized trials. Sometimes you just have to use whatever evidence. What is the heading on the SAGES guidelines say? It says a large amount of moderate quality information can lead to a strong recommendation. Now, surgeons maybe are a little bit different than medical oncologists. We actually see new things, we try them. If they work in our hands, then we'll continue to use them. That's a little bit of our mechanism of does it work, does it not work. I understand that the phase 3 trial is very important, but I've added to Dr. Glasow's list of historical examples of treatment with dramatic effects that became standards of care without randomized controlled clinical trials. Interesting. I-131 for thyroid cancer. You know, standard of care has been that way for almost 30 years. Never had a randomized control. It just worked so well. The disease changed when this targeted therapy came in. Gleevec for GIST. You try and learn how to use the Gleevec, but the trial, yes, no, will never be done. Combination chemotherapy with cisplatin for testicular cancer. Well, I added to that surgical resection of 1 to 3 liver metastases and chemosurgery for appendiceal carcinomatosis and peritoneal mesothelioma, and I'm convinced small volume colorectal carcinomatosis. So, let me just go to the last slide because I've used up my time. It's now 9 o'clock. I think there are some conclusions that can be drawn at this time. And again, many thanks to PMP Research Foundation for showing us the way that this very powerful new tool, this new multimodality tool, should proceed. I think data to support cytoreductive surgery plus high-tech as a standard of care for appendiceal cancer, peritoneal mesothelioma, and low to moderate volume of colorectal carcinomatosis exists. Doesn't say that every patient has to be treated that way, but I think that patients should know what the treatment options are. Data to support systemic chemotherapy alone as a standard of care does not exist. And actually in the trial that's proposed, there is no systemic chemotherapy at all. Systemic chemotherapy and then a crossover to chemosurgery. We might, in our discussion, as we go through the course of the day, think through some of the internal and external issues, and a lot of it is just inadequate research and not enough people thinking together, medical oncologists and surgeons, thinking together as to how this should be done and how these new treatments should be offered within the constraints of our current healthcare system to patients who have this disorder within the United States. Anyway, that's my comments, and I look forward to the rest of the day and to sharing with you thoughts about where we're going with this very real problem. Thanks a lot for your attention.